Clinheim, Hematology, Demystified.
Okay, morning again. Today we're going to go through thalassemia. This is the fourth week in our preparation series. This will be the layout. We'll start with definition and types. There are unfortunately lots of definitions and classifications used to describe thalassemias. And then we will discuss very briefly about diagnosis, and management will be quite case-based. And I did think about it, how much I should cover with this session, because thalassemia is as easy or as complicated as you want it to be. I finally concluded that I think because this is the first session, and some of the colleagues um, would like to cover basics, as they actually mentioned to me privately as well. So I would mainly cover alpha and beta thalassemias here. Um, would Diagnosis, I think, requires a separate session. So, the HPLC and things. So we will try to fit that somewhere, maybe with our mock session, which is week 7. And the aim for this session is to cover mainly the basic guidelines that I shared with you at the start of the week. So that especially if you did go through, this will serve as a really nice revision for you to hopefully consolidate that in your memory. And this will be reflected by using a case, which is, of course, a fictional case, but maybe a little bit of details are inspired by real life experiences. Okay, so finally, going to start with definitions. When we think of hemoglobinopathies, there are actually two types of them. So thalassemia is a quantitative defect. So a person would make low amounts of hemoglobin and low amounts of normal hemoglobin. And this is because of a globin gene mutation or deletion, which results in either reduced alpha chains or reduced beta chains. And of course, being called alpha or beta thal respectively. And then they will have excess of the opposite chains, which actually cause the problem. And this leads to imbalance in the chains. Normally, there is quite a nice balance between the two chains to make good amounts of adult hemoglobin. And as opposed to them, the structural variants, also actually called hemoglobinopathies, um, are qualitative defects, as you know, and they're again mainly from mutation in the globin gene. And depending on the mutation, it leads to a particular variant like HBS, CD, or it can lead to unstable hemoglobin or methemoglobin, etc. And you can have a mix of the two. So there are conditions in which a person would make less hemoglobin, and whatever they make is actually abnormal as well. So say hemoglobin E. And whatever you see on this slide, um, a person can have a mix and match of different things. So alpha with HBS, alpha with HBC, beta with HBS, beta with HBC. So basically they can have a mix and match. And as you can see how complicated it can get, that's why, as I said, it would be as complicated as you want it to be. But with this session, I will try to keep it uh, simple and build upwards towards the complexities of alpha and beta thal. So where does thalassemia fit into these hemoglobin disorders? So as you know, hemoglobin is actually a molecule that contains two main parts. So four globin chains and heme. Heme is a being complex of iron and protoporphyrin. So which can have abnormalities in either and give you porphyria or even iron deficiency and things like that. But globin chains are two alpha-like and two beta-like. So two alpha-like globin chains and two beta-like globin chains make up the four globin chains. And the abnormalities can be in the form of decreased production, which is thalassemia. And this is what we're going to cover today. And then if these abnormalities and abnormal hemoglobin, it will give you an abnormal hemoglobin, which could be one of these. So if they crystallize For example, deoxyhemoglobin in sickle cell would form a sickle-shaped crystal, that's HPS, and or they could have become unstable hemoglobins, become a hemoglobin with reduced or increased oxygen affinity, or cause hemoglobinemia. It can be a mix of the two as well. Now, so before going into what's abnormal, we need to know what is normal. And most of you would already know this, but this is the most important thing actually in hemoglobinopathy diagnosis, at least, to know what is normal. So this is a normal adult hemoglobin, two alpha chains, two beta chains. Each contains a heme molecule with iron in it to carry oxygen around. And so there are two options. Basically, there will be any type of hemoglobin would have two alpha or alpha-like chains or two beta or beta-like chains. In adults, as you know, this is made up of two alpha chains and two beta chains. What I mean by alpha-like and beta-like is that there are some other chains. So alpha globin chains are located on chromosome number 16. So this is of course alpha 1 and alpha 2 gene, which gives rise to alpha chains. But there are other chains which are alpha-like this epsilon over here. But this is expressed way early in embryonic life, so not a lot of significance for us if you're doing adult. So mainly, predominantly, the alpha chains are made, alpha actually. So other alpha-like are not um, so relevant. Beta chains, there are a few beta-like chains. Of course, beta is one of them, but then there are other beta chains. So in embryonic life, this is epsilon, and then gamma chains are also beta-like, and delta chains are also beta-like. So there are a few. All of these are located on chromosome number 11. Now, why this is important is that this is in embryonic life, these two. So we will forget about them for now. This is gamma chains. They would start in early fetal life. They are very important because they remain um, even after the birth, at least up to 3 to 6 months. And as you know, there are lots of different useful clinical indications where we want more fetal hemoglobin. So options to make hemoglobin after early fetal life. So we're going to ignore this and this. You need two alpha chains and two beta chains. The only option you have is alpha. You don't have any other alpha-like as an option after early fetal life. So either the alpha can combine with gamma to form alpha 2, gamma 2, which would be HPF, or they've got an option to combine with delta chains, and this will make alpha 2 delta 2, which is HbA2 seen in adults in a very small percentage, mainly important for diagnostic purposes, as we will discuss. Or, as you know, in adults, so they have got the option of, and they would love to bind beta chains, and that would be alpha 2 beta 2, and that is the predominant hemoglobin in adults. That's why HbA. So, as you can see, the options are alpha. Alpha is the only option for alpha-like chains, and for beta, you can either have gamma, delta, or beta chains and form the respective hemoglobin. But as you know, we have pair of genes in our cells, so we actually have each one of us has two pairs of genes. So one's from mom, one's from dad. As you can see, for alpha chains, alpha globin chains, there are four genes in total. So these four genes are going to be responsible to make, two, so to say, alpha globin proteins for one hemoglobin molecule. And similarly, we'll have two of these. So we have two beta chains to make two beta globin proteins per hemoglobin molecule. And this is just a general rule here. So four alpha genes alpha genes do the job of two beta genes. So if you have 50% of them, you usually do okay in terms of the production of so if you have 50% of normal functioning genes, you do okay in terms of a reasonable amount of production of the respective chain, respective globin chain, basically. So if you basically need at least two of the alpha chains to be functioning normally to produce enough normal amounts of alpha chains, you need at least one beta chain to make enough normal beta chains. There are some exceptions. That's why usually, but I would not go into the detail here at the moment because I'm trying to build it from the very basics, as I said in the beginning. In health, the expression of these four chains is balanced against the expression of these two beta chains quite nicely, to the effect that balanced amounts of alpha and beta globin chain is synthesized so that you do not have any excess of alpha chain or excess of beta chains, because both of them in excess in isolation will cause problems. So if they are nicely in the form of a hemoglobin with two alpha, two beta, that's good, essential for life. But if there is any excess of one or the other, they are pathological on their own. Yeah, so they're pathological on their own if they are in excess. Now, this is the most important slide of knowing about hemoglobin synthesis, because not just for theoretical purposes but for diagnostic purposes, and all of your HPLC would be based on this knowledge. So this is birth, and this is the prenatal life, and this is postnatal life in weeks, and this is the percentage of globin synthesis on the y-axis. As you can see, I have actually omitted the very early embryonic alpha and beta like chains. I've just left the chains that make hemoglobin after say 4 to 6 weeks of gestational age. So as you know, you need two alpha chains. So the only option is alpha. So you need two alpha chains to make a hemoglobin molecule. The only option is that you have alpha, but there's a lot of variety which beta-like chain you can use to make hemoglobin at the various stages of life. So prenatal age, the predominant beta-like chain is gamma chain. So the hemoglobin that would be predominantly present in fetal life is HPF, because 2 alpha, 2 gamma. So gamma, alpha to gamma 2 is HPF. The baby will start making beta chains in small amounts, so there would be some HPA present in babies at as well. So to the extent that at birth, around 20 to 30% of hemoglobin would be HPA. So if you see here, so you have alpha, and maybe you have around about 20% of beta chain expression. So you can think of it like, okay, 20% of the alpha chains will bind with beta chains to form hemoglobin, which would be 20% HbA type, but the rest of the 80% of alpha chain will bind with the gamma chains to make the remaining, which is around 80% of the the hemoglobin. So that would be hemoglobin F around about 70 to 80%, and neonatal hemoglobin A would be around about 20 to 30%. If there have been problems with birth, like prematurity and things, of course, they will be born here somewhere. So you can see that the HbA levels would be low and HbF would be high in people, in babies who are premature or have other problems during birth. After 3 to 6 months of age, roughly, basically at around 3 to 6 months of age, your gamma production is basically starting to, go down. Beta is going to go up. So around about 3 to 6 months of age, the only option to make good hemoglobin should be alpha and beta, and the predominant hemoglobin in type in the blood should be HbA, so 97%. There will of course still be small amount of gamma chains being produced, so there would be some HbF throughout life, which is less than 0.5% usually in health. And HbA2, so as I said, there are delta chains which are present in very small amounts. So there, some of these alpha chains would bind with delta to make HbA2, but the percentage would be, and this is very important to remember, up to 3.5%. Why all of this happens is because hemoglobin F has got more affinity to attract oxygen. So that's what you need when you're a baby, so that you can across the placenta and things, you can get more oxygen and take it to the baby. But afterwards, you can survive with HbA. How do you? So these are some important numbers. You probably already know them by heart, but just one, mnemonic, so to say, to remember. HbA2's upper limit is this two actually should come up here, superscript. So 1 to 3.5, so 3.5 is the upper limit of normal for HbA2. And I will explain how we use that to diagnose beta thalassemia trait in a second. Any questions up till here? I'm intentionally going very slow because sometimes this confuses a bit, but this is quite straightforward otherwise. Good. So, other way around. So, what happens in alpha and beta thalassemia? There will be imbalance of alpha and beta chains. In alpha thalassemia, most common cause is deletions of alpha chains. So remember, we have 4. So if there is deletion of them, that leads to less production of alpha chains. In beta, usually there is mutations in the beta chains that leads to less production of beta chains. Alpha chain abnormalities, no surprise, would start manifesting in early fetal life, because to make hemoglobin, you need alpha-2 and beta-2 alike chains. So alpha-2 is the only alpha-like chain that's present predominantly from the very start. Beta chain abnormalities usually appear to cause symptoms around about 3 to 6 months of age when they start to be expressed. So alpha thalassemia major would appear in fetal life. Beta thalassemia major baby would be normal until the age of 3 to 6 months when they start getting anemic and things. Okay, so what actually happens if you have alpha or beta thal? So one of the chains would be produced in low amount and the other one would remain in excess. This imbalance is not good because the excess of the chains, alpha or beta, cause lots of problems. In the stem cells, they can cause stem cell death, as in the progenitor cells, and this will lead to ineffective erythropoiesis. To compensate for that, the body will try to increase the erythropoietic drive. So not only intramedullary hematopoiesis will be increased, but also the body will recruit the other organs like liver, spleen, etc., to make more cells, to do more hematopoiesis. And this will cause problems. Of course, hepatosplenomegaly can be seen, and expanded intramedullary hematopoiesis can cause bone problems. And as you can imagine, if it happens around the spine, it can cause problems like cord compression and things like that. So even though the body is trying to compensate with increasing the hematopoietic drive, it will still remain ineffective because the cells that come out, they also have those abnormal excess in alpha or beta chains, and that will precipitate in the cell and cause membrane damage and things, and that will lead to their being hemolyzed and easily removed from the spleen and tight spaces in the spleen, for example. So chronic hemolysis would give you gallstones, and pulmonary hypertension as two very important complications, among other like thromboembolism. Then one of the mechanisms because the body's mechanism are designed, if body thinks that the person is anemic, maybe I just need to make more cells, more red cells, and that will overcome the problem. And in doing so, they will try to absorb more iron. Now, ineffective erythropoiesis on its own can cause increased iron absorption from the GI tract by inhibiting hepcidin. So dying stem cells release some markers which are going to go and inhibit hepcidin, and then more iron will be absorbed. This alone on itself can lead to significant iron absorption, leading to iron overload. But of course, when they're anemic, they require transfusion, and that can cause transfusion iron overload. Iron overload is not great because, yeah, so if iron overload happens in the body, our body has got no mechanism to excrete excess iron. The only monitoring or the regulating step is at the absorption stage by, for example, by changing hepcidin levels. But once iron manages to come inside our blood and the tissues, there's no active way to excrete iron. So unbound iron, when it reaches a certain value, it will start depositing in the organs and cause lots of problems, especially, where is it gone? Starting with liver. Oh, I missed the liver. So first, it starts usually in thalassemias. It starts usually in the liver, and then it can cause problems in other organs like endocrine organs and the heart. The heart as well for some reason. That's strange. And this is now good when it starts depositing in the liver or the heart for obvious reasons. We will discuss in a bit more detail. And any endocrine organ can be involved, starting from the top to bottom. And of course, bones would be weak as well, just because of not only because of ineffective erythropoiesis, but also because of vitamin D problems and things like that, and parathyroid problems. Many of these things lead to increased thrombosis risk, and that's also one of the big problems. This also goes high if a person has had splenectomy for some reason. Now, one of the important things that I wanted to highlight from here, and they were likely to check in the exam, is a pulmonary hypertension. Sorry, somebody's asking me how do I join. They just messaged me. Give me a second. Just send them the link. Sorry about that. Okay. So that's why, and this is not something that we normally do, come across routinely. So I just made a separate slide out of that. But otherwise, each of the things that I mentioned in the previous slide has got chapters on its own. Pulmonary hypertension is a poor prognostic marker in any condition, more, so to say, in thalassemias and sickle cell, for example. You monitor with at least an annual echo. The gold standard method is quite invasive to right heart catheterization is quite invasive. So we have indirect methods like annual echo. The UKTS guidelines suggest if the annual tricuspid regurg velocity is more than 3, then it is considered as significant, and the person should be referred for formal investigations like right heart catheterization, etc. And they are sent to the specialist clinic to also consider treatments with these medications. And this is what you do. So if the TRV is less than 2.5, you just continue with annual echoes and address any reversible factors that you can. And if it's between 2.5 to 3-ish, you see if the person is asymptomatic, you just continue with the monitoring. If they're symptomatic, you refer them for further tests. And if that confirms pulmonary hypertension, they will try to do something for that specifically. But of course, we need to address the hemolysis and those things from our side of view as well, which we will come to in detail. Pulmonary hypertension happens a lot more commonly in non-transfusion dependent thalassemias than transfusion dependent thalassemias. And it's probably thought because maybe that in transfusion dependent we are transfusing, so preventing it. That's one of the reasons. Okay, so other thing, iron overload, as I've mentioned, main problem. One of the main problems is depositing in the cardiovascular organs, the heart. That is the cause for mortality in quite a few of them. And it causes mortality by a few mechanisms, either by heart failure, which can be acute or chronic. We have to remember, and they're likely to trick you in the exam by giving you a normal ejection fraction of a patient with thalassemia and who is in heart failure, but they have high output cardiac state, so their high ejection fraction is quite, normally quite high. So even ejection fraction in the quote unquote normal range should make you very worried. Arrhythmias are very important, and palpitations are taken very seriously in thalassemia. The risk of, especially the ventricular tachycardias and things, goes quite high. So any palpitations you have to discuss with the cardiology team and optimize their heart failure and iron chelation and transfusion, etc. And this can happen even when they do not have enough cardiac iron overload at the moment, but might have had significant overload in the past because the damage might have been done. Of course, it leads to pulmonary hypertension, and chronic thromboembolism is also a problem which can lead to pulmonary hypertension. So actually, when you do diagnose pulmonary hypertension, one of the things that we do is to make sure they do not have undiagnosed chronic PEs, for example. Liver, damage causes liver cirrhosis, can lead to HCC, seeing more and more commonly in thalassemia patients now because the life expectancy is getting better. Endocrine, as I've mentioned, with iron chelation, good iron chelation from young age, they can avoid most of these problems, and they can have puberty spontaneously as well. Otherwise, hypogonadism, hypogonadotropic hypogonadism can cause significant fertility and puberty problems. And most of the, any endocrine organ can be affected, starting from the top, thyroid, parathyroid, thyroid, growth hormone, insulin, which is diabetes, cortisol as well, rarely, and bone problems, including from vitamin D deficiency and things. Iron overload, and this is an important slide to just, and with some important differences between the two types. I will come to the details of transfusion-dependent thalassemia and non-transfusion-dependent thalassemia, what we exactly mean, but of course the name is quite obvious. So when do you start looking for it? The ways to look for iron overload is ferritin and MRI scans. MRI being way more superior than just a ferritin. The ferritin is are important, as we will discuss later. So when do you do an MRI scan? You do one for the heart and for the liver. The liver, the ferry scan, which is the R2 scan, is better. It is being more validated, and it gives you a reading, an output in the milligram per gram dry weight rather than a value like the cardiac T2 star, which gives you a value in milliseconds. So anyhow, for heart, we still do cardiac T2 star MRI, which gives you a value in milliseconds. And we will discuss some targets and ranges in a bit. But when do you do them? For transfusion-dependent thalassemia, you have to do them before 8 years of age. And for non-transfusion dependent, if they so non-transfusion dependent thalassemia patients are more likely to develop transfusion overload as well if they do start getting transfusions. Also because they are undiagnosed, so to say, because we don't think, oh, they've not had enough transfusions, so they probably do not are not iron overloaded. But as I said, ineffective erythropoiesis can cause higher iron absorption on its own, which can remain undetected. But if their ferritin is more than 800 when they've never been transfused, which is lower number than what we use for transfusion dependent, which we will discuss, or if they previously have evidence of iron overload. So usual progression of iron overload is that first the iron stores get saturated, then transferrin gets saturated, which is the binding protein for iron, and the excess floats in free form, which is non-transfusion bind iron. This is the toxic form. Most commonly, what happens is first organ to be affected is the liver, and then iron overload starts going in other organs like endocrine and the heart. But once you start iron chelation, the reverse is true. Actually, not the reverse. The same is true. Liver is the first to get rid of the iron. So heart can lag behind, um, you know, in from iron chelation point of view. So you might have to give quite a bit of iron chelation if your target was removing iron from the heart. You have to wait quite a bit before you are able to sort it out. Now, when do you start iron chelation? When in transfusion-dependent thalassemia, if they have more than 10 transfusions or ferritin goes in more than 1,000, so as opposed to lesser target in non-transfusion dependent. And you start with monotherapy and you combine, and there are some reasons to combine which are obvious, like failure to achieve negative balance, or if the liver or the MRI or the heart gets significantly loaded. There are values available on the guideline, and this is from there. So liver iron concentration, if it goes more than 7 milligram per gram dry weight, or MRI T2 score less than 20%, or there's a reason for emergency intensification, which is low LV ejection fraction. As you can see, 56 is not a bad number, but for them it is, or if the T2 star is less than 8 milliseconds of these clinical arrhythmias present. We have to remember we avoid overchelation. If you keep giving chelation when there's not enough iron, then there's nothing to chelate, and what the person would end up with is more side effects um, uh, than benefit. Yes, Akram, sorry, Adnan, you got a question, sorry.
Just a quick question regarding the non-transfusion dependent thalassemias.
Mhm.
I don't understand what we mean when we say previous IUL, because the patient would already had
Yeah,
MRIs planned, isn't it?
yeah, yeah. So there's a separate slide coming on there, but basically ferritin is not too reliable in non-transfusion dependent thalassemias to monitor iron overload. But if a person has never been transfused and you see a ferritin of more than 800, you get worried and you confirm the iron overload doing MRI scans. Yeah. But if they previously have had iron overload, we know from the history that previously we've done a scan. No, we don't not a scan, of course, but we know that they have history of long-term transfusions and they've got endocrine problems and this and that. We suspect that they have iron overload. Then, or if they are on chelation already, then ferritin, you don't rely on the ferritin to start looking for iron or confirming iron overload with MRI scans. So if they've never been transfused, and even if you're not suspecting it, if the ferritin is more than 800, it's a good idea to look for um, confirm iron overload with MRI scans. If you think they previously have had iron overload, or if they're already on chelation, then you don't wait for the ferritin level to go above 800 to do a baseline scan.
Okay, thank you.
No worries. I will keep hitting these numbers again and again till it sits. But I've got a few more slides to come to do them, so don't worry if you don't remember them. Now, just briefly, very briefly about how pathogenesis reflects in electrophoresis. And as I said, we'll probably do another session because this will take hours on its own. So when there's alpha-thal, as you know, as I've said, you at least need two of them normally functioning to give you decent amount of alpha chains, and the body can compensate. So if body loses one, then the expression of the others can be increased to make enough chains. But if it drops to uh, more than two genes being abnormal, then you cannot make enough alpha, and as a result, you will have some beta in excess. Now, if you see any of these, so either one is the problem, one mutation or two mutations in alpha gene. So you've got two functioning genes. If you do any protein based mechanism to check the hemoglobin percentage, the percentage would appear normal. Why is that? So that's because, as I say, either they will have enough to make enough alpha chains, or all of the hemoglobins will, because alpha is required to make all types of hemoglobins, HbA, HbF, HbA2. So if they are decreased mildly, all of them would be decreased proportionately. So the overall percentages would appear normal. So alpha thal you cannot diagnose with HPLC or CE because they will appear normal. Alpha thal trait, I mean, silent carrier or trait. So when one's off, you say it's a silent carrier. When two are off, you say it's a trait. If both of them are off on the same allele, you say this is a uh, um, cis version, which is which for genetic counseling purposes is worse compared to if one is off on each allele, which is called trans version. It's because if this person with this kind of genotype um, has a baby, then there's a risk that they can pass this side to the baby, which has no alpha chains. And if the dad also has, or the other partner also has, passes this, then, or even this, then you can imagine the person will end up with either one alpha chain or zero alpha chains, which is not good because that as we discussed, will give you symptomatic alpha problems. So I've explained why it's normal in trait and silent carriers. But once you are down to one or no alpha chain, then you start seeing beta and beta chain like tetramers. You cannot see good hemoglobins like HbA or HbA2 or as in an HbF. All of them would be decreased because alpha is required for all of them. But you would also start seeing excess beta chains, and which they form tetramers. Now, when in fetus, as you remember, gamma chain is the one predominantly being produced from the beta side. So those gamma chains would combine together and form gamma 4 tetramers, which is hemoglobin BARTs, B for baby. But it's the same problem if the same baby becomes an adult or at least after 3 to 6 months of age as gamma production slows down and beta takes over, and now still the beta now hasn't got any alpha to bind, so the beta this time would be in excess, and they will a beta 4 tetramer is called HbH, H for human or whatever, but B you can, so basically it's the same problem in different stages. So in the fetal age and up to 3 to 6 months, they will have lots of gamma 4 tetramers, which is hemoglobin BARTs, and beta 4 tetramers when they are above 6 months of age, predominantly. These can be detected on blood film by special stains, but also on electrophoresis, or HPLC, they will give you distinct patterns. Now, coming to beta-thal, as I said, if you have at least 50% of the gene functioning okay, that's good enough. So if a person has got one abnormal gene, so beta 0 means they are not producing any, a mutation is causing, there's a mutation which is leading to no production at all. So even if they have one normal functioning, they could have make good beta chain amounts and for decent HPA, and that is alpha to beta 2. But still there would be a little bit of excess of alpha chains, and alpha chains have got the option, as you remember, in adults to bind either beta to make HPA or delta to make HPA2. So these little bit of excess that's there, that will bind delta to make HbA2 in more amounts than normal. So the HbA2 goes above 3.5%, but only up to 8% in a beta-thalassemia carrier. So if you see microcytic hypochromic anemia, raised red cell count, because that will help differentiate from iron deficiency. In iron deficiency, you'll also see hypochromic microcytic anemia, but the red cell count will be low as well, as opposed to thalassemias, because they will try to make more red cells from ineffective erythropoiesis, even though they're hypochromic microcytic. And then you do electrophoresis, it shows decent amounts of HbA, but shows HbA2 is slightly up, and the ferritin is normal. Then this is good enough to say this might be a beta-thal trait. If they have no, if a person has beta 0 mutations, then they cannot make any beta chains. So this means that they will have normal hemoglobins up till the age of, say, not normal, but they will have HbF in good amounts till gamma chain is still ongoing till around 3 months of age. So they will not have any problems. But then as soon as gamma starts switching off, and it was time for beta to start doing their job at 3 months of age, because it is the only beta light chain that's going to remain there, a person would start making, developing symptoms, because there would be no normal hemoglobin A, and they can only make HbF and HbA2 because in whatever amounts they can. But because there is no HbA, they will have severe consequences, and that's unfortunately one of the very common presentations. So, mom and dad would be carriers. They would have never known it if they've not been screened. For example, they would never know they have any problems. And so if they have they are beta-thal carriers, they would never have any problems. But then suddenly they have a baby who they don't know has inherited the, both abnormal genes. And once baby's okay, doing okay until about 3 months of age, and they suddenly start to, not suddenly, but relatively gradually start appearing to have problems, then it's a shock that, they have got beta-thalassemia. That's why the prenatal counseling and screening is very important. So briefly, there are lots of ways to classify, and it can get as complicated as you want it to be. But there's pathogenesis based, which is how many genes are mutated or deleted. So in alpha-thalassemia, it can be a silent carrier with only one loss. Trait has got 2 losses. HPH has got 3 losses. Which can, and HPH can be actually be loss, can be deletion of the gene, or it can be non-deletional. So the gene is present, but it's present in a dysfunctional way. So even if it's producing some alpha chains, they are not normal. So actually have no normal alpha chains, and they are actually worse than deletional ones, because they reduce the production of alpha chains quite dramatically, and the alpha chain that's produced is not stable at all. It also causes other problems like worsening hemolysis and things. Alpha thalassemia major is when there is no alpha gene. So that's one of the ways. So heart fatalis has many causes. One of the causes alpha thalassemia major. So a baby would start having problems intrauterine fetal life, maybe after 4 weeks or so, when alpha was going to be the main gene. Beta thalassemia trait, when one is off. Beta thalassemia intermedia, I will discuss. Beta thalassemia major, when both are abnormal genes. Yeah. An easier way to classify and clinically more relevant is a shift towards this is to classify them clinically, either as a trait, which they do not have problems in themselves, but they are still important to diagnose because of the risk of transferring the trait versions to the baby and causing problems, giving them an illness, either non-transfusion dependent thalassemia or transfusion dependent thalassemia. So non-transfusion dependent thalassemia are still symptomatic, but they do not depend on transfusions for their survival, but they can have dips like with infection, surgery, pregnancy, where the hemoglobin drops and they will require transfusions. Transfusion dependent thalassemia are like beta thalassemia major or alpha thalassemia major that require blood transfusion for survival, otherwise they will die. So in beta thalassemia, for example, without transfusion, a baby would unfortunately pass away. And very unfortunately, this still happens in many parts of the world. They pass away within 2 to 5 years of age. If they are only supported with transfusions, then they can live up to maybe 12 to 15 years of age, but then iron overload catches them, and they unfortunately succumb to that. But with good transfusion and good iron chelation, they can have a life expectancy easily of more than 50 but it comes with a lot of burden. Like to check how some alpha thala HP bars and some hydroxytalis. Yes, a slide is coming on that. Yeah, that was just an introduction. So this is the slide that will hopefully help you answer that question. Now, what do you see in silent carrier? Just one gene is mutated, and this is very, very, very common in the world. And good way to find out is the FPC hemoglobin and MCV might be normal, to be honest, but the MCH usually is a bit low, and that's what we use to screen for in our plans, in our screening programs. The hemoglobin analysis would be normal, the hemoglobin electrophoresis or hemoglobin HPLC or capillary electrophoresis would be normal. A trait would have two mutations, deletions, and they can either be on each allele, which is less dangerous. So the person would be normal again, but less dangerous in terms of passing on to the baby. But this one is more dangerous because if they pass this to the baby, then and they have also have one or more gene mutated from the other partner's side as well, that they can end up with this or this. So HBH is when they only have one. So your question was why some alpha thalassaemias HB bar, some hydroxytalis. Yeah, because hydro. So with this, you still HBH, we're still making some alpha chains. So still you have some hemoglobin A production, but there would be other problems that this might not be enough to give them a decent hemoglobin, so they will have moderate to severe anemia, and the excess gamma chains in newborns would appear, which is hemoglobin bars, and when they are after 3 months of age or 6 months of age, they will have beta 4 tetramer, which is SPH, and in after 6 months, it might be up to 30% in HPH. The rest might be HPA, so that's why they still might be doing relatively okay compared to this. But this has got a very wide, HPH has got a very wide spectrum, as I will show you a slide in the end. There's quite heterogeneous when it comes to presentation. But there's got no alpha chains, so you practically have no normal hemoglobin for the stage. So fetal hemoglobin HbF is required for after say 4 weeks or so in intrauterine life. So baby would develop severe heart failure in utero, high output cardiac failure, edema, effusions, and things, and that's what the appearances are called hydroxytalis. So it would be fatal in utero unless in utero transfusions, and rarely, and has been done in utero transplant has been done as well, which can give them a chance to survive. They will have no HbA, HbF, or HbA2. The only intact hemoglobin they might have is the embryonic hemoglobin, which I showed you at the beginning. So maybe using those alpha-like chains, which are otherwise irrelevant, but they're not very good to do what HbF was supposed to do, so they don't do very well. And they will have quite a bit of HbA parts in their blood. The reason to highlight these in red are that they will quiz you in MCQs for screening. So when you see, they will make a person to have alpha-thalassaemia like features, and then they will give them a high risk ethnicity for this cis mutation, where the mutation is present on both on the same allele. And this is what one of the conditions that the screening programs aims to detect is HPH disease, because it can have severe consequences. So to detect it in pregnancy and give informed choices to the parents, if they would like to terminate the pregnancy or at least be ready for what's coming and be counseled accordingly. So these mutations on the same allele are present in lots of ethnicities, as you can see, but mainly Chinese, Southeast Asian, and some others, including Greek and Turkish. And they usually will give you one of these ethnicities, Vietnamese or Chinese, and they will try to quiz you on that. And this is an open book thing. They will definitely ask you a question on that. I hope that answers the question that was in chat. Now, coming to beta-thalassaemias, mutations are of few types. So beta 0 is if a person inherits that, they're not going to make any beta globin production. And then beta plus, where beta plus, where they will have low beta globin gene production, but this defect is variable. Some of them will be mild, so they only mildly reduced production, but some can be moderate, so moderately reduced production. So beta 0, of course, is worse than beta plus. Presents at 3 to 6 months of age in severe forms, especially, as I said, because there was time to switch to predominantly to HPA. So this slide will help you with beta-thalassaemias. We'll start with what's normal. Genotype is beta beta. Yeah, that's what I said in the beginning. So HPA is 97, HPA2 is up to 3.5%, HPF is less than 1%. In trait, you will have one abnormal, either beta 0, beta naught. And the only thing that will help you is the HPA2 being high, up to 8%. More than 8% are seen in some other conditions, which we will discuss in another session, hopefully, because it will complicate things. So, because they've got decent amounts of HPA, they are they are asymptomatic as far as they are concerned, and this is not an illness. In major, easy to know, they either have both beta 0, or they have beta 0, beta plus, or they have severe beta plus, the moderate versions of beta plus in both sides. They will have, may have some HPA if they've got beta plus, but in beta 0, they will have no HPA. And A2, maybe, the only option is to make fetal hemoglobin and alpha-2, so they will try to make it. Alpha likes to bind with gamma chains more than delta, so the predominant hemoglobin will be 50 with HPF. But the problem is these are all percentages. The actual amount of hemoglobin would be low, but whatever hemoglobin is there, it will be predominantly HPF. Now in between is intermediate, is mix and match of these two. So as you can see, as the name suggests, they are not normal, but they're not too abnormal, like they're not major. And the HPA would be in a range of 15 to 65%. HPA2 would be here, and HPF can be, according to what the HPA is, you will have HPF. Delta is, as I said, not expressed quite a bit. That's one of another reasons that, you don't see a lot of delta produced. So the HbA2 is usually under 10 in thalassemias. There are other reasons where you can have high quote unquote HbA2, which we will leave it for another day. Now, how do you get intermedia? Either you get homozygous beta thal with beta 0 and mild beta plus, or you get heterozygous beta thal. So the minor ones, but now either you make the minor ones, but you have an extra alpha copy, so alpha duplications are present. What this will do is this will make the imbalance worse. So even though the mutation was otherwise mild, this person would otherwise be a carrier. But the problem is they've got extra alpha as well, and this will ultimately lead to excess imbalance. Same here. They have major beta, which is one of these, but they would have been major in thalassemia major, but they have also inherited alpha thalassemia, so the imbalance is reduced a bit. So they fit in the intermediate category. If a person has something called hereditary persistence of fetal hemoglobin, so their fetal gamma globin gene doesn't switch off, which normally switches off say 3 to 5%, then they will have quite a good amount of HPF. So HPF is still good. A person wouldn't be symptomatic. They might be anemic, but they wouldn't be symptomatic. And that's what we try to do, as you know, when we're giving hydroxycarbamide, say to sickle cell, trying to induce more HPF, because hydroxycarbamide, by one way or the other, tries to increase the HPF percentage. So it helps make this phenotype less severe. There are lots of others. You can look into Hofbrand, and I've purposely not mentioned there because it will confuse, and I'm happy to take questions on them afterwards. Now, this is a good summary slide if you don't want to know all of that, and I wish we could just do that. The person can be either a trait They are either non-transfusion dependent and transfusion dependent, whatever their genotype is. In alpha, take alpha-thalassaemia trait, one mutation, of course, no transfusion. HPH deletional is on a spectrum, either no transfusions or occasional transfusions. HPH non-deletional, like Constant Spring, is on a spectrum, is worse than HPH deletional. So where, HPH is basically where you only have one gene. So you will be on a spectrum of either, a person will be spectrum of either having occasional transfusions or regular transfusions. Alpha thalassemia major is incompatible with life without transfusions from in utero life. And then beta thal trait doesn't cause any problems, so no transfusion. Intermediate, the name suggests, can be okay, can be non-transfusion dependent, can be transfusion dependent. And beta thal major is, as by definition, transfusion dependent and require regular transfusions for survival. Yes, normal person can have, that's not a silly question. Normal person can have active persistence of fetal hemoglobin, and they probably would never find out unless they have a blood test or other reasons. And yeah, HPF is perfectly compatible with life. To diagnose, you do a history and exam, ethnicity, physical exam, a previous history of a family history of previous anemias and things. You check their FPC, most important parameters being hemoglobin, MCH, and MCV, as I discussed. Blood film is important. You will have hypochromic microcytic anemia and lots of moleculocytes, including target cells and things like that. And electrophoresis, hemoglobin identification can be done by protein chemistry method like HPLC or CE, or molecular methods like PCR and gene sequencing. There are other methods, but these are the two commonly tested in exam. And this is what the slide frame would show. Beta-thalassemia, for some reason, gives you more NRBCs than alpha-thalassemia major. And supravital stain will stain the HPH to give you golf ball-like cells. So you can just Google that. It's very nice blue cells with lots of dots, which are basically tetramers of the excess beta chains, and appears like a golf ball. And I actually am going to keep track of all the special stains that give you special features for, benign hematology, malignant hematologies. And at the end, I will just give you like a template or a PDF to say this stain is important for this, just for remembering purposes. Now, coming to the management, and it's time for me to stop talking and hopefully have some interaction, because it is impossible to cover all of the guidelines, and it's very dry that if I keep saying, narrating all of that to you. So I've tried to make this into a case to try to cover all the guidelines that we were going to cover in the week, and hopefully this helps. So we will start with this case of a 28-year-old Pakistani woman, first pregnancy, attends routine booking visit at 10 weeks gestation. How do you screen for hemoglobinopathies in pregnancy in the UK? Anybody?
I think it's based on the prevalence of hemoglobinopathy in an area.
Yeah.
Low prevalence, less than 1 per 10,000, I guess, and then high prevalence. And then there is an area between these two.
Yeah.
So
So very good. So basically less than one, so an area where less than 1% of the screens, hemoglobinopathy screens, have been seen to be abnormal is low risk, a low prevalence area. Anything above 1, so 2 or more, is high prevalence area. So a place where 2% or more of the hemoglobinopathy screens have been seen to be abnormal, they are high prevalence areas. And so she's a Pakistani woman, so even if she's in low prevalence or high prevalence area, her family, so you would do an FBC and a family questionnaire in everybody anyway. So she will be flagged up from the family questionnaire. She's a Pakistani woman, high risk for her.
Electrophoresis of both parents.
Sorry, come again.
Electrophoresis of both parents. Both parents electrophoresis before.
Yes, we will do electrophoresis of both parents. Yes, when we are going to do it. Yeah, but if they say electrophoresis of both parents, only those who are found to be at risk. So I'll explain that in the next slide. And it's not moving. Oh yeah, it's moving now. Everyone gets an FPC when they're booking for pregnancy. For the concept of hemoglobinopathy screening, so high prevalence areas, 2 or more, everyone also gets a family origin questionnaire. Everybody gets actually a family. Everyone gets an FPC and a family questionnaire. In high prevalence area, they get a family origin questionnaire to see where their family is from, what's their ethnicity, where's their biological parents' ethnicity. And if they're high risk, they also get one of the methods to screen for hemoglobinopathy. Most commonly used in the UK is HPLC as first line. But even CE, capillary electrophoresis, is a good enough answer for screening. But in the UK, we use HPLC most commonly. Low prevalence areas is less than 1%, so they just get an FPC and a family origin questionnaire to start with. In the FPC, if the MCH is less than 27, so their red cells are hypochromic, then you do a family origin questionnaire and along with, so you do HPLC as well. So everybody gets a family origin questionnaire. If their MCV is more than 27, which so basically suggests that the hemoglobin in per cell is okay, so maybe they're not at risk for thalassemia. But if their family origin questionnaire suggests they are from high risk, you do HPLC for them. And if they're low risk, you do not do anything else. So for her, because she's Pakistani, so our family origin questionnaire is going to be high risk. So she's going to have an HPLC anyway. So everybody gets FPC and family origin questionnaire. And if they're in the low prevalence areas, the MCH also helps. So this is how you do it. So she will get an FPC and HPLC. So FPC shows here. Anything else that you would like to see in the FPC itself, which I haven't shown? Just to help you, as in see what might be happening.
Ferritin level.
I've given you
Yes.
the first. That's fine.
Maybe red cell distribution good.
Yeah, very good. Another, even before that, simpler. The red cell.
Retic count.
So retic count, yeah, down the list, yes, but more important, red cell count. Anybody tell me why?
Because it is
Low
high
can be seen in
compared to
traits.
thalassemia.
Sorry, come again.
I
Sorry.
was saying low count can be seen in traits.
So traits will, so basically to help you differentiate, and this is not set in stone, but just give you an idea, like a feel of it.
Menser index.
Yeah, exactly. So there are lots of indexes which help you differentiate between iron deficiency and thalassemia traits. Both can have similar FPC findings, like hemoglobin MCV. So, or both of them can have anemia and maybe hypochromic and microcytic, right? But the red cell count would be high in thalassemia traits usually and low in iron deficiency. And based on these parameters, there are lots of indices, like one of the colleagues has mentioned, Menser index, to see if these parameters might be from a thalassemia trait or iron deficiency. In the UK, we do not rely too much on those indices to have the final word, but this is a good way to say. So when we say a person has quote unquote thalassemic FPC findings, what we trying to say is they are microcytosis hypochromia with raised raised red cell count, as opposed to iron deficiency. They will have low MCV, low MCH, and low red cell count. And I think Yawa mentioned red cell distribution width. So what happens to red cell distribution width in iron deficiency as opposed to a thalassemia trait?
It will be high in iron deficiency.
Yes. And why is that?
Because of the reticulocytes.
Yeah. But if there's severe iron
it
deficiency,
defines the anisocytosis, the size of the
Yeah.
red cells is different.
Yeah, that's correct. So a reticular, if you have severe iron deficiency, you will have low retics. And thalassemia as well. If you have very severe, not traits maybe, but if you have severe thalassemia, so severe ineffective erythropoiesis, then you will have low retics as well, because whatever is happening in the bone marrow. Not enough cells are there in the terms of retics. But anyhow, RDW, red cell distribution width, checks the range of the size of your red cells. So if the red cells are of different sizes, let me try to draw something. So say this is a person has red cells of various sizes. Yeah, they're not this big, but anyhow, and there is another person who has red cells of the same size. So who's going to have a high RDW? The top or the bottom?
The top.
Top one, yeah. So they will have high RDW because the distribution width is what is, as the name as it suggests on the tin. So this is going to see if there is any variation in the size of the cells. If all of them are small, then the RDW would not be high. It would be okay, as in it won't be high. It will be normal. But if it's the different shapes, then they would have increased different sizes. Sorry, they will have increased RDW because they some are small, some are large. What would be the MCV in the top one and MCV in the bottom one, if this actually reflects exactly equal numbers of their red cells? MCV in this one, we are actually deflecting from the topic, but anyhow, what would be the MCV in this and this?
Top one would be somewhere maybe around, let's say, on the higher side.
Okay, so not
And
low.
very-
Not low, yeah, in the top one. So maybe normal or maybe high, yeah. So normal or high. In here, low,
low, yeah.
because they're very small. Maybe this is a normal size red cell and these are big and small. So mean cell volume, MCV, is the mean of all the cell volume. So RDW tells you the width or the range of the sizes. Mean cell volume tells you the mean. So mean here would be low, but the mean here might be normal or even raised if there are lots of, more bigger cells. So anyhow, that was just so going back. So yeah, so this patient has increased red cell count, my writings, and then they also have increased RDW, and their, oh my god, RP, no RPW, RDW. Anyhow, the 7 you try to write with the mouse. Ferritin is normal. So what does it look like? It looks like a thalassemia trait. Yeah. Now this could be alpha or beta. We're not sure yet. So what I would try to do, how do I get rid of mouse? Yeah, so we'll do an HPLC, of course. So this is what the HPLC shows. And I've not gone into the detail, but I've mentioned what this is supposed to show. So anybody can take a quick shout.
Yeah, it will be a
was
beta
beta.
trait.
Yeah. Why not alpha
A2
trait?
A2 is high. Yeah, HbA2 is
Yes.
high.
Yeah. So
More
if it was alpha
distribution.
trait, what would you have seen in the HPLC?
That's usually normal or low beta. A2, sorry.
Yeah. In trait, you would see a normal percentages. So HPLC would be normal. This because all the hemoglobins are low. In trait, as I say, if there are two genes mutated, as in deletions, then the rest of them can compensate. So overall hemoglobin might not be low anyway. But even if that is low, all the hemoglobins would be low because this one, all of them require alpha chains. So if alpha trait is a problem, either the hemoglobin is normal, or if they are low, all the different types are low. So the overall percentages will appear normal. So hemoglobin electrophoresis in alpha would be normal. This is not alpha, this is beta, as we can see, because beta chains are low. So there is some excess of alpha which have a chance to bind with delta, and they give you an increased delta. Okay. The diagnosis and next steps. So we know this is beta thalassemia trait most likely now. So what are we going to do next now? Patient sat in your clinic with the HPLC results.
Partner testing. I mean,
Yes, and what do you mean we tested the partner with? Do we just look at them or? What are we going to do with the partner?
I'm not sure. Is it HPLC or full blood
Yeah.
count and HPLC?
Exactly. So same thing with the partner. Full blood count, HPLC or CE. And I would like to say, we would say the father rather than the partner, because what if they've got a new partner and we're checking somebody random? We need to see who the father is. So we're checking the father if they're available. That's why I had it in bold. And they have similar findings. So they have also got similar FPC and this. So what have they got as well? Beta thalassemia trait. So what are we doing now? You're seeing both of them now in front of you. Both have beta thalassemia trait. She's 10 weeks pregnant. What's the
And
risk
then
with?
there is 25% risk for the baby to have beta thalassemia major.
Yes. So what we say to them?
Breaking
Is-
bad news.
Already.
We would refer them maybe for
Where?
Feto-maternal unit.
getting a diagnosis.
Amniocentesis.
I don't know, it will be too early, I think.
Yes.
10 weeks.
So no amniocentesis, but the other version, which is chorionic villus sampling. So you will refer them for, you will speak to them first. All the answers are okay. So you will speak to them first and say, look, your baby's got 25% risk of developing beta thalassemia major, which is a life-threatening condition. After 3 months, this is what's going to happen. They will be transfusion dependent, iron overload, this, that, the other. But it's only a 25% chance. There is a chance that they might just have a trait as well. So to differentiate that, what you would like to suggest to them is we can do prenatal diagnosis. So prenatal diagnosis is done by doing chorionic villus sampling if early in the pregnancy, or if they don't want that now, amniocentesis. Chorionic villus sampling earlier is better, because if you know the diagnosis, say by 11 weeks or 12 weeks or something like that, then you are going to do genetic tests, etc. So you do that. Then, because if you check the babies, you can't. You check basically by genetic tests here, and there are strict guidelines that these kind of tests are supposed to have a quick turnover. So as early as we can find out, if we know that the genetic test comes out to be beta thalassemia major, now you can sit them down and say, look, this baby has got beta thalassemia major. It's likely to develop thalassemia major after 3 months, and these are the consequences. So what would you like to do? Would you like to continue with the pregnancy, or would you like to think about termination of pregnancy? And with the next pregnancy, we can think about doing peri-implantation, diagnosis, IVF or something like that, to select a good embryo and etc. etc. Or would you like to continue with the pregnancy? So it's a very big decision. This is the first baby, so it's not in real life an easy decision. So we just respect their decision, of course. So we see what they would like to do. So this patient declined having, she said, oh no, too risky. I can't take a chance. So no sampling with my tummy, please. My first baby, what are you doing? I'm not, she understands fully what the risks are, but she said, no, I would just like to leave it like that. I wouldn't want to have any test. Now, is the baby, so that's where you're seeing at maybe at 10 weeks or so. Anything else we need to do during the pregnancy for now? Baby at risk of anything during pregnancy? From the hemoglobinopathy side of things.
Maybe we do a viability scan.
Growth scans.
We can, yes, we can do growth scans and things, exactly. But if this is beta thalassemia,
Folate.
Yeah, folate and things, the normal things are very good. So if this is beta thalassemia, even if the baby has beta thalassemia major, and we do not have any indication of that the person might have alpha thalassemia as well inherited, so we're just focusing purely on beta thalassemia, then the baby would actually be fine. Baby would be fine up till 3 months of age. Even if they have beta thalassemia major, they won't have problems till 3 months of age. So this is what happens with them. They have uneventful pregnancy. Healthy baby girl is born at term, and a cord blood was sent for hemoglobinopathy screen from the baby. What do you expect to see in the cord blood? I showed you a table at the very beginning, but
We will see the fetal hemoglobin predominant.
very good. How much alpha?
Alpha will be 100% because they have no alpha-thalassemia.
How much hemoglobin A I wanted to say? Sorry, my fault. How much? So you said hemoglobin F would be predominant, which is normal. Yeah. How much
Yeah.
HbA would you see in cord blood?
In this patient, it will be less than 30% because they have no beta.
Yes. Yes. How much A2 would they see? Would you see? A2 actually, the delta gene comes down. A delta gene starts expressing down the line. Let's leave that. So this is the baby now. Baby girl. Cord blood shows that HbF is 95%. HbA is absent. HbA2 is absent. Is this normal electrophoresis for a baby boy or baby girl? Sorry, or baby boy, but newborn.
Thank you for watching. Stay tuned for more.